All attendees are in listen-only mode.
Welcome to the PeriRx webinar, Integrating Salamark OSCC into your oral cancer screening protocol. We appreciate everyone who is logged into this webinar, and we are excited to share this information with you. Many of you are currently using Salamark. Some of you have registered your practice and are ready to get started, and some of you are interested in learning more about early detection. What we all have in common is that together we want to make a significant impact on the morbidity and mortality of this deadly disease. At the end of the presentation, you will be able to ask any questions you may have by typing in your question in the box on the right of your screen. Also, we are supplying handouts with information from the various slides as well as copies of our brochures. You can print or download them from the right side of your screen under the Handouts section. I would like to now introduce Dr. Jack Martin, Chief Medical Officer of PeriRx.
Thank you very much for that introduction, and I also thank everybody who's taken their time to log into this webinar. We're going to discuss early detection, integrating Salamark OSCC into your oral cancer screening protocol. By way of disclosure, I want to point out that I'm a co-founder of PeriRx and the Chief Medical Officer with equity in this company. Oral cancer, according to the National Institutes of Health, affects over 45,000 people in the United States who are newly diagnosed each year. More than 8,000 people in the United States will die of this disease this year. And the mortality from this disease has not significantly improved in decades. Importantly, the age of onset for oral cancer is often below the age of 55 in the prime of life. This disease should no longer be thought of as a disease of older men. A major risk factor for oral cancer is smoking. There are 45 million Americans who smoke cigarettes. There are also 45 million former smokers in the United States. Smoking and alcohol are additive in terms of their risk for oral cancer and really a deadly combination for the risk of developing the disease. Nonetheless, we have to keep in mind that 25% of patients diagnosed with oral cancer have no lifestyle risk factors. They're not smokers, not heavy drinkers, and no other lifestyle factors that would put them at risk for this disease. So we have to be cognizant of the fact that all patients could potentially develop this deadly disease. Unfortunately, approximately 2/3 of oral cancers are found in stages 3 or 4, often with no pain or other symptoms reported that would help the patient or their caregivers to suspect this disease before it's in late stage. Largely related to late diagnosis, oral cancer results in more deaths in cervical cancer, melanoma, liver and kidney cancer, as well as testicular cancer and Hodgkin's disease. Putting this into perspective, one person dies every hour of every day from oral cancer in the United States. This data from the SEER registry shows the relationship of stage of diagnosis to survival. You can see that patients with localized disease have a much better 5-year survival rate than patients with regional or distant spread. If you look at the pie chart on the left, you can see that only 31% of patients are diagnosed with oral cancer with localized disease. Most patients have regional and distant spread at the time of diagnosis. And again, survival and stage of diagnosis go hand in hand. Oral cancer is a very costly cancer to treat. This is also data from the SEER registry. The blue bars show the cost of treating this disease for different stages of care in 2010, with over $3 billion of expenditures. The green shows a projected cost by 2020, where it's expected that the cost of treating oral cancer will be over $5 billion in the United States. And this is not due to inflation, because this is all calculated in 2010 dollars. Oral cancer costs nearly $100,000 per patient to treat. This is twice the cost of most other cancers. The majority of people treated for oral cancer are unable to return to work, so this is another cost to society besides the medical costs and the human costs. Importantly, if caught early, patients are more likely to return to work, and there are reduced medical costs of care. So let's talk about the value of salivary diagnostics. Over 10 years ago, in initial discovery studies in the laboratory of Dr. David Wong at UCLA, they discovered a panel of salivary transcriptome markers, which are messenger RNAs, that distinguish oral cancer from normals. They found early in this work that the salivary markers were better than blood tests. Here you see the area under the ROC curve, which is a measure of the information content in your test, and that was better for the salivary messenger RNA or salivary transcriptome than for blood tests. These markers were subsequently studied by the National Cancer Institute Early Detection Research Network in a study of almost 400 subjects. In that independent evaluation, the National Cancer Institute concluded that the validation of these biomarkers showed their feasibility in the discrimination of oral squamous cell carcinoma. The prospective blinded trial performed by ParaRx after the National Cancer Institute study was identified as the next necessary step to further validate the National Cancer Institute findings. In this prospective blinded study, it's important to note that 71% of the patients with cancer had T1 and T2 lesions. This has been a consistent finding across studies in the National Cancer Institute Early Detection Research Network studies, as well as in the earlier studies at UCLA. They also found that these biomarkers performed as well in early stage disease as they did in late stage disease. In this prospective study, we validated all 6 of the pre-specified oral cancer-associated messenger RNAs in an intended use population of patients with suspicious oral lesions. We also identified and incorporated robust internal housekeeping genes for a highly discriminatory multi-marker predictive model suitable for commercial use. In this study, low-risk test scores at 96% sensitivity for detecting cancer had over 98% negative predictive value in what was a high-risk population in this study performed in tertiary care referral centers. The negative predictive value would be expected to be even higher in populations commonly seen in screening programs with a lower incidence of disease. So let's talk about what is meant by cancer screening. It means detecting disease early in asymptomatic people. Importantly, in most cancer screenings, positive results do not in and of themselves make a diagnosis, but they identify people at increased risk for the presence of cancer who warrant further evaluation. Dentists and hygienists are on the front lines for fighting the battle against oral cancer. An oral exam is taught as the gold standard of care in dental and hygiene schools. Yet, according to the National Cancer Institute, only a minority of Americans report receiving an annual oral screening examination. So primary providers must lead the charge And it all starts with a thorough history and physical exam to be done during routine dental and medical visits. Importantly, the dental hygienist, when performing a routine screening examination, can perform the Salamark test after they confer with their uh, dentist, um, who agrees that the patient is at risk and this test would be warranted. Screening examinations have their limitations in terms of what you can discern with the visual eye itself. Take a lesion like this. Uh, is this a benign lesion or a malignant lesion? This is very difficult to discern just on the appearance. Consider these chronic lesions, leukoplakia and erythroplakia. When in the course of following patients like this is it time to consider that there's been enough change to warrant further evaluation and potentially a biopsy for concern of development of cancer? This is where the game can be won or lost in determining when it's time for a patient to have further evaluation. And it's our intention to have people stop assuming as to whether or not it's time to consider further evaluation and start doing objective testing that could help in this decision. So Salamark is the missing piece in your oral cancer screening protocol. Today, you can implement this accurate, simple, and painless salivary DNA test into your practice. You have the opportunity to change patients' lives. Early detection of this debilitating disease can reduce disfigurement and potentially save lives. Salamark OSCC was developed to specifically help quantify the risk of oral cancer after a concern is identified during a screening evaluation. The quantitative test result is a very effective tool to identify patients at very low risk and those at increased risk that would benefit from further evaluation or referral to a specialist. Now let's consider some other adjunctive screening tools for other cancers. You can see that breast cancer has had a dramatic decrease in death rates after introduction of mammograms many decades ago, and this improvement has been sustained over decades. The same is true for cervical cancer after the introduction of pap smears. Prostate cancer has had a decrease in death rates after the introduction of the PSA test, but it's important to note that all of these uh, other adjuncts that are potentially life-saving aids do not in and of themselves diagnose cancer. Someone with an abnormal mammogram is at higher risk for cancer and needs to be evaluated further with other potential imaging tests or for repeat testing, perhaps several months down the road, before a specialist then makes a decision about doing a biopsy. PSA is a biomarker test as opposed to an imaging test like a mammogram, and therefore is similar to the Salamark test, which is also a biomarker test. In order to assess the accuracy of PSA tests, you have to look at studies where everybody had a biopsy of the prostate regardless of the PSA results. That's similar to how our prospective blinded trial was done, where everybody underwent oral lesion biopsy regardless of our biomarker results. In these studies, PSAs had a false negative rate of over 15%, even with repeated testing over 7 years, and even after excluding patients with abnormal rectal exams. So you're excluding the highest risk patients, and there still is over a 15% false negative rate, even with repeated testing. In another study in the New England Journal of Medicine, where all patients were biopsied regardless of the PSA status, you can see that the sensitivity and specificity of PSA testing at the current cutoff levels is 79% sensitivity with a specificity of 59%. The negative predictive value of this test is lower than what we showed you for the Salamark test using our present test cut scores. So we could conclude that the sensitivity and specificity of Salamark, as well as the negative and positive predictive values, compare very favorably with other biomarker tests such as PSA. However, given that oral squamous cell carcinoma is a much more aggressive disease than prostate cancer, we believe that the primary provider's decision for referral should be based on a test score cutoff that maximizes sensitivity at 96%. In other words, the sensitivity of a PSA of 79% we feel would be inadequate for cancer such as oral squamous cell carcinoma. So, the superior predictive accuracy of this test is based on over 10 years of National Institutes of Health funded scientific studies, with over 900 patients now studied in the Salamark research program. The accuracy is also attributed to using a multi-marker model where 3 cancer genes are incorporated into a single test score to enhance the performance over single marker tests. The Salamark test, when it has a low risk score, is a very strong predictor of freedom from cancer, and high risk scores are associated with a 2 to 3 times increased chance of cancer. So when is this test indicated? The test is indicated for use after an at-risk patient is identified on screening examination. It can help the doctor make a more accurate decision on whether to refer for consideration of an invasive biopsy or to follow the patient clinically. Now, how about for practitioners who use visual aids in their oral examination when screening patients for oral cancer? If you currently use a fluorescent screening device to perform an oral examination, Salamark can then help you better quantify the risk of any mucosal abnormality that you may find. So this test can be applied when you have a patient of concern, whether they're identified with a normal ambient light examination or whether you use a visual aid. Comparing Salamark to other cancer screening tools, this is the only test where the markers were independently validated by the National Cancer Institute Early Detection Research Network. The only test where the markers were specifically studied for the intended use in patients with suspicious oral lesions to distinguish benign oral lesions from malignant oral lesions. It was specifically designed to give a quantitative risk rather than a subjective qualitative assessment. It incorporates multiple markers into a single quantitative score to increase the predictive value. And it was studied in prospective blinded trials as recommended by the National Cancer Institute. So how do you apply the test score when you perform it in a patient? So you have a patient with a suspicious lesion. The Salamark test is then done. We believe that the primary care provider should base their decision on whether it's a low-risk score or a non-low-risk score. Any patient that is not a low-risk score, we believe, should be referred to a specialist for another opinion. The moderate and high-risk scores, we believe, should then be taken into account by the specialist along with their individualized assessment of this patient based on their history and physical exam to then make a decision as to whether or not they're going to follow this patient clinically with early follow-up or whether they're going to proceed with a biopsy in this patient earlier on. So how do you actually take a sample in a patient? We've made the process very simple to easily fit into the workflow of your office. The test kit shown on the left here contains all the materials you need to perform this test. For convenience, the instructions which we're going to review are on the inside of the box cover, readily available to review at the time you're performing a test. The patient simply rinses their mouth with water and then spits into the collection funnel that's attached to our sample tube. The patient needs to provide 1 to 2 mLs of saliva. The funnel is discarded and the tube is capped. The tube is then shaken in order to help the pellet on the bottom of the tube, which contains our biomarker preservative. When the pellet dissolves, the sample will turn color. You simply record the name and date of birth on the label, place the labeled tube in a biohazard bag. You then register the patient for the test with a HIPAA secure link on our website into the laboratory information system. When you register the patient, a barcoded label is generated that you print out and send with the sample in the shipping envelope. There's a prepaid FedEx label that is used to pay for the shipment, and you simply call FedEx to pick up the specimen. We recommend that this should be done the day the specimen is collected. Our preservative does stabilize the biomarkers for up to a week, so if you forget to ship it or for some reason can't ship it that day and have to ship it the next day, that can be done. So let's talk about the fee structure for this test. The test kits themselves are sold in a box of 10 for $199.99, so approximately $20 per test kit. Now, what should the practitioner charge for administering this test to the patient? We do not set the practitioner's fee. We feel that the practitioner should bill the patient for their time to examine the patient, perform the salivary test, check the results, and counsel the patient. And they should do that based on their best judgment as to the time that they put into evaluating this patient and performing the test. The laboratory fee for the molecular DNA analysis costs $180, and this fee is billed to the patient or to the practice at the discretion of the practice, however they want to do it, at the time that the test is administered. Now, how about reimbursement for these charges? Key to medical reimbursement is establishing the right diagnosis code with ICD-10 codes. These are provided on our website for your convenience for coding the patient properly for insurance submission for this test. The lab service fee for Salamark would currently be submitted to medical insurance using code 81599, which is for a multi-analyte assay with algorithmic analysis. That's a laboratory test that takes several markers, as our test does, and combines them into one single test score. The dentist charges can be submitted for reimbursement either by the practitioner or the patient using existing CPT or CDT codes. These codes are provided on our website for convenience, and as we discussed, the exact level of service should be determined by the practitioner based on the particular case at hand. You can find detailed information about these codes on our website, along with ADA and CMS claim forms to make it convenient for you or your patient to submit to insurance for reimbursement. To summarize, Salamark OSCC is based on more than 10 years of NIH-supported research. The quantitative results are based on molecular DNA laboratory analysis. This helps to detect cancer in its earliest stages. With 96% sensitivity, there's nearly a 99% negative predictive value of this test. It is a highly effective tool for identifying patients at very low risk and those at increased risk. It's simple and painless. It's non-invasive and easily incorporated into oral screening protocols in your office. It takes the guesswork out of your decision to refer a patient for further evaluation. So, fighting oral cancer is a team effort. We're a company that's in the Philadelphia region. That's why I show you the picture of the Phillies. We're hoping that they'll do a better job in the next few seasons than we've had recently. But with a team effort, everyone achieves more. The dentist and hygienist on the front lines are the key players in this team. And ParaX would like to be a member of your team by providing you with an advanced molecular technology that can help in your decision making in these patients at risk. I thank everybody for your time. For more information, you could go to our website, www.parax.com. You can also call our office to speak to our clinical specialists or to me about any particular medical or scientific questions that you want answered in more detail. And you could also send questions to info@parirx.com. At this point, we're going to open this up to questions by the audience. You could type in your questions in your panel on the bottom right-hand side of your screen. So the first question I have is, what does the test actually measure? So as we discussed, this test is measuring messenger RNAs, which reflect increased activity of genes that have increased activity in the presence of oral cancer. So it's a test for genes that are more highly expressed or more highly active in the presence of cancer, and that's the presence of cancer now. We're not genotyping people to detect a genetic inherited propensity for having cancer down the road. It's measuring gene activity that correlates with the likelihood of cancer being present now. Another question I have here, do we have other tests in the pipeline in the field of salivary diagnostics? That's an excellent question. I appreciate it. So our oral cancer test is the most advanced of our platforms, having been studied in numerous cohorts at UCLA and then by the National Cancer Institute Early Detection Research Network before our prospective blinded trial. We have a prospective blinded trial ongoing right now that's close to finishing enrollment for patented salivary biomarkers for the detection of oral cancer. We hope to have the results of that trial available by the second quarter of 2016. This would be a test that would be used in at-risk patients, smokers, and former smokers to decide on the need for a low-dose CT scan, which people probably know have been shown to reduce mortality in lung cancer. But the National Cancer Institute, having completed a very large trial on CT scans, concluded that biomarkers were necessary as a companion to make CT scanning better. We also have additional diseases, adult type 2 diabetes and early detection of diabetes. We have our initial work done in that field and are just now launching a prospective blinded study for early diabetes detection. And we also have a product in the pipeline for detection of Sjogren's syndrome through salivary biomarkers. Another question I have here is, how do you use Salamark in a patient where you don't see a lesion? Well, our primary indication is when there's a lesion of concern and you're unsure as to whether or not this is one that should be followed or should be considered for a referral for consideration of early biopsy. Since we've been in the marketplace, we've had a number of practitioners call us about patients that were high-risk patients due to heavy smoking and alcohol consumption, or both. And they did our test because they were concerned that they might be missing something. In this situation where that test comes back at high risk in a patient of that nature, if you're concerned that you missed a lesion, you then could use these test results to decide that you should get a second opinion from a specialist to make sure you didn't miss something on your examination. Or if you're fairly certain that there's nothing on examination that you missed, you would then use this test to put that patient on closer scrutiny, see them in early follow-up, and of course counsel them about their lifestyle and modifying their risk factors. So thank you very much for all of those excellent questions and for your attention. And please contact us if any questions at all come up where you would like further clarification. I hope everybody enjoys the rest of their evening.